Hello, hello. Testing. Hello, hello.
for the introduction part. Dr. Sharad, over to you.
Yeah, sure. Hello everyone, good evening and welcome to our symposium on the combination of metformin, SGLT2 inhibitor and DPP4 inhibitor. So we have with us here today a well-renowned clinician and academician, Dr. Bipin Sethi sir, who comes with 30 plus years of experience as an endocrinologist, currently working in association with Care Banjara and Nampally. Sir is also a lifetime member of ESA and RSSGI and a visiting faculty of the National Institute of Nutrition of Hyderabad. Sir has contributed to more than 200 plus research articles published in various Indian and international reputed journals, with major focus on diabetes and with multiple publications on our SGLT2 inhibitors as well. So it's an honor for us that you are available to speak about a new combination of FDC of metformin, lemogliflozin, and vildagliptin. I also like to welcome all the doctors who have made their time and come here on a Sunday evening. Please welcome. So there's a chat box for questions. You can pose your questions there and we'll be taking up these questions at the end of the session. Over to you, sir.
Thank you, Dr. Sharad. I am humbled by your introduction and I'll try to do justice to the topic. We have, I'll just see if this is moving well. Yes, it is moving well. We are today here to discuss the issues around glycemic control. We know that glycemic control is difficult because of the nuances of the disease and the fact that many a times we make wrong choices of agents which inherently have some issues regarding their tolerance or safety. And I refer specifically to the incidence of hypoglycemia. Imagine a patient whom you are starting on treatment and the agent can effectively control the glucose but also produce hypoglycemia. How confident will you be and your patient be in chasing the target that you assign to the patient? So that is the Achilles heel for agents which cause hypoglycemia. But coming to what are the needs for diabetic management, not just in our country, but also globally, is that we have to have a good glycemic control and a drug that efficaciously lowers the HbA1c. If you can have an agent which acts independent of beta cells and also adds to durability, then it's quite good. If you have an agent which avoids some of the side effects which contribute to less aggressiveness or inertia, which causes complications, then it is welcome. If you also are looking at what might improve the compliance or concurrence with the treatment, then that is also important. And then the most important factor in our settings when patients are paying from their pocket for the treatment is the ease of treatment and the economy of therapy. As we stand today, we have multiple publications showing that the HbA1c levels in observational studies from the hospital and from clinics are far from the desirable targets. If you look at studies published by way of DiCare or having some issues about diabetes care in India, you find that the HbA1c is hovering around 9%, if not more than that. And that is a sad state of affairs. In the Landmark study, which was in the TIDE study, which was done across the country, they found that poor glycemic control was there in 76.6% people, and microvascular complications were there in 35.7% of individuals. We are aware that the primary cause for hyperglycemia, how many inputs you might have, 8 or 11 for hyperglycemia, the primary event is beta cell dysfunction, to some extent incretin effect, and there is a declining beta cell function at the face of static insulin resistance, which leads initially to postprandial glucose elevation in most people, later fasting plasma glucose, and you have the micro and macrovascular complement, which is something which everybody knows about. Which needs, therefore, then to the need for, apart from lifestyle modifications, of choosing one drug, up titrating it to the maximum possible dosage or tolerated dosage, choosing another drug, and then maybe 3 drugs, and finally, when they fail, you do increase the drugs, and then nothing happens, and you add an injectable therapy, which would be GLP-1 analog theoretically, practically the insulins. Now, from the Wikipedias, it is well known that if you control the diabetes early, you decrease the relative risk for the macro vascular events, also decrease the incidence of heart failure, which is much talked about these days. Second issue, if we leave the control, is the issue of adherence to therapy. When a therapy is prescribed, you find that up north, you have only less than 1/3 people who are compliant. Somewhat better in Western India at 41%. South India and the Eastern India, probably from Calcutta, have got slightly better adherence rates. And these are important, that the centers in the north and in the west were the tertiary care centers, whereas the other centers were primary care centers, and that in the east was both primary and tertiary care center. Also, diabetics don't have diabetes alone. They do have many other illnesses. And if you take patients, total patients less than 65, more than 65, you require more number of medications for individuals who are elderly. And this is number of tablets per day, be it for hypertension, be it for cholesterol, be it for, say, cardiac issues. And on the right, you have got number of oral antihyperglycemic agents. You find that many people are on 2 or 3 agents. Very few people are on 1 agent. And there are, of course, very a minuscule number who are on no tablets. And this means that an individual has to, on an average, swallow between 4 to 6 tablets, of which 2 or 3 might be that of anti-hyperglycemic therapies, and he might not know which one is very important, relevant, and he might miss one particular agent. If you are looking at this picture, which is sort of borrowed from the Omnius octet that was described by DiFranzo, you find that there are numerous inputs, and some agents address one, other agents another, and some address only one issue. For example, SGLT inhibitors address only glucose absorption, nothing else. So if you are using multiple agents with different addressing different pathophysiological mechanisms, then you are likely to achieve good control. If you are going to use combination therapy, be it all things combined in one tablet or added as 2 different tablets, you have the possibility of using complementary actions of these drugs for early attainment of target, improved glycemic control, of course, a reduction of complications and better compliance. And this is something which is open to combinations. We also know that even injectables, people are trying to combine not just prandial and basal insulins, but also insulins, basal insulins, and GLP-1 analogs. So there is a shift in trying to demonstrate the efficacy of these medications and then administer them as combinations. In the agent that we have, if we look at efficacy, the efficacy is, of course, more with injectables, followed by metformin sulfonylureas. But one has to also understand that these studies were done when HbA1cs were very high. In head-to-head trials, sometimes we find that SUs have got similar degree of efficacy as DP4 inhibitors or SGLT2 inhibitors. Hypoglycemia risk, as I said earlier, is with insulin, and of course with SUs and meglitiner. It is not there with other agents. Weight gain occurs with the SUs, insulin, and glitazones. Metformin can cause weight loss as a neutral, but you actually have loss with SGLT2 inhibitors and GLP-1 agonists. Safety and tolerability of most of these agents is having one issue or the other, but the side effects are generally rare with DP4 inhibitors. The cost of therapy is high for injectables and had been high for DP4 inhibitors and SGLT inhibitors till the advent of certain cheaper DP4 inhibitors before the loss of patent or expiry of patent for vildagliptin, introduction of teneligliptin, and also now there is some issue about the patency of many other molecules. So the cost of the molecules have changed, but remains a little bit higher compared to the sulfonylureas. CV benefits were demonstrated in very small number of patients with metformin, but they have been shown certainly with SGLT inhibitors and GLP-1 analogs. They have not been shown with any other agents. With glitazones, of course, you have the tendency for heart failure or edema and sometimes fractures as well. So if you look at a combination, then you have some kind of a mix wherein you retain efficacy. Inherently, if you choose these three agents, you have low hypoglycemia risk, you have possibility of weight loss, you have got CV benefits because largely of SGLT inhibitors, but also of metformin. So you have got a possibility of giving many benefits to the patient apart from glycemic efficacy in terms of weight, in terms of blood pressure, and in terms of certain CV benefits. As I told you that if the cost of therapy can be reduced, then everything becomes green or yellow. Now, there is some evidence that compared to the possibility of taking the same agents as 3 or 4 pills, if you choose a single pill, there is a decrease in the non-compliance by about 1/4, a little over 1/4. There has been a study which looked at for 3 years the same very impact, and they showed that there was higher change in adherence, persistence, and smaller change in the number of drug prescriptions. So reducing the pill burden might improve compliance, and of course control has also reduced the complications. Now, this is also important that if you are increasing the adherence, you are going to have more improvement. And if you decrease the adherence, you will find that there is increase in the HbA1c. So you have got benefit with increase in adherence, and of course negative impact on if you decrease the adherence. There was a panel which was international panel with representations from many countries, which was published in the Journal of Family Medicine, which looked at the issue of FDCs in management of type 2 diabetes mellitus. They opined that FDCs double or triple improve patient adherence, reduce the cost, and play a crucial role in achieving glycemic targets effectively. And they also say specifically that one should be trying to use rational combinations, not irrational combinations, and have a good safety, efficacy, and tolerability. And the rationale for using the drugs were that they should have different mechanisms of actions. The pharmacokinetics should be close to each other rather than far different. the combination should not have additives that can produce supra-additive toxicity, and the combination can be chosen based on the recommendations of the guidelines of the agents which are in the pill. So the available FDCs in our country, as we know, the one is the metformin, sulfonylurea, and glitazone, the triple drugs. The second one is alpha glucosidase inhibitors. These, of course, are addressing different mechanisms. The pharmacokinetics are similar. Recommendations by guidelines is less for alpha glucosidase inhibitors because they are not generally generated in the Asian context. But there could be some increase in toxicity by the metformin sulfonylurea glitazone combination, largely because of glitazones, which cause additional weight gain to sulfonylureas and also some tendency for edema. But if you look at the metformin SGLT2 and D4 inhibitor combinations, you find that there is no supra-additive toxicity, and this actually satisfies the other criteria of different mechanisms of action, similar pharmacokinetics, and recommendation of the components by the guidelines. This is the ACE algorithm. The 21 looks almost similar. It suggests that if you have got HbA1c more than 9 and the person is asymptomatic, or you want to choose triple agents, you can use metformin with SGLT2 inhibitors and with DP4 inhibitors. So this is something which has been recommended by the guidelines also. In January last year, US FDA also approved the metformin DP4 inhibitor SGLT inhibitor combination as an FDC, and this was a news in that particular country. If you look at the way in which the inputs to hyperglycemia are addressed by this combination, you find that most of the defects are left untouched by SGLT inhibitor. They only act on the kidneys. But if you look at combination of metformin and DP4 inhibitors, they address more effects, but together these three drugs address all the 8 inputs for the hyperglycemia. So I think this is something which is important, relevant. Inflammation is also addressed by SGLT2 inhibitors. The gut microbiota are also addressed by the DP4 inhibitors. So you have got multiple things that can be addressed. As far as the efficacy is concerned, these drugs produce significant reduction in HbA1c. They have got issues of protection of the renal and cardio through the SGLT2 inhibitors. They do not have any overlapping toxicities. They do not increase the risk of the cardiovascular events or weight gain or hypoglycemia. In fact, the SGLT2 inhibitor and D4 inhibitor combination decreases the incidence of genital mycosis. They are, if given in this manner, they produce a cost-effective reduction in the HbA1c, and it is possible to introduce them to the oral route. SGLT2 inhibitors, as we know, are the drugs which cause weight loss, blood pressure reduction, have a potential for cardiac protection with certain agents, and renal protection in terms of not just reduction in proteinuria, but also the doubling of the serum creatinine need for renal replacement treatment, as also a decrease in renal deaths. This has been demonstrated with some of the SGLT inhibitors. And in the meta-analysis of CVOT, it has been found that you decrease the major cardiovascular events, you decrease the heart failure, you decrease the progression of heart disease, and all these events are possible irrespective of ASCVD, except reduction in MACE, which is seen more clearly and only in people who got pre-existing atherosclerotic cardiovascular disease, not seen if you do not have prior ASCVD. This is the same thing that we were talking about, that MACE, CV death are reduced, and also there is a reduction in the, sorry, I'm unable to, in the MACE and CV death were definitely reduced, as also was the incidence of heart failure. There are, of course, reviews on this which talk about the effect on the cardio-renal outcomes, which also talk about the same thing. If you look at the DP4 inhibitors, yes, they do not produce any cardiovascular benefits, but the risk for CV mortality is also not increased, and there are studies with some of the gliptins which show that barring saxagliptin, there was actually no increase in the heart failure, no increase in the cardiac events. Metformin, the component which is a third component, also was known to decrease the complications in overweight diabetics compared to certain allurias. And there are some other studies which have looked at the cardiovascular benefits of metformin, and they have shown that the all-cause and cardiovascular mortality was decreased by metformin, and there was about a 19% reduction if you look at the overall meta-analysis for CV mortality, and a 33% reduction in all-cause mortality. And there was also past evidence which showed decreased risk of cardiovascular morbidity and mortality with metformin, and this was, of course, also a robust kind of data with the confidence intervals not crossing unity. So both metformin and SGLT inhibitors have some suggestions for improvement of cardiovascular morbidity and mortality. The second issue which was raised earlier was that of cost. Now, when we look at the cost, we look at the cost which is immediate to the consumer for the purchase of the medications, but we must also balance it with the cost that is there for treatment, say, of hypoglycemia, loss of work hours because of hypoglycemia, transportation for worker, for reaching the hospital in COVID or non-COVID times, and the cost of the complications which might occur because you have not used the drug or titrated the drug optimally because of fear of hypoglycemia. I think these factors should also be considered for the cost considerations, not just the immediate payment or immediate financial burden to the individual. So they try to compare a combination therapy with branded DP4 inhibitors and SGLT inhibitors versus generic alternatives. And what did they say? They said that generic medications compared to the DP4 inhibitors and SGLT inhibitors may be cost effective. But if you look at the sequence, there's increased cost compared with genetic pathway, but improved quality adjusted life years by 0.24. And costs are partly offset by reduction in diabetes complications and delayed insulin initiation. So this is important. Also, I might say that there's something which we cannot quantify. Two individuals who are sitting in the room, one who is on SUs and insulin, which can cause hypoglycemia, other one who is an SGLT inhibitor, D4 inhibitor, and metformin, both having excellent control. The person who is on non-hypoglycemic producing therapies is more confident of not having a problem of hypoglycemia, and he can continue to attend a meeting like this or any other meeting thereafter. Whereas the person who is on insulin or on sulfonylurea will always be living under the threat of hypoglycemia. Then we come to the issue that we have at hand. We did talk about what is the burden of diabetes, what is the percentage of poor control, why people are not reaching control, the nuances about these drugs, how might these drugs address these different pathways, how they might produce a better control, but is there any proof? So we are going to discuss a study which received approval from the regulators in our country for marketing a fixed dose remogliflozin with metformin combination. This was based on the Forever study. Some of you might be aware of this and might have also, say, been exposed to these kind of slides earlier. This was done at 23 sites in the country. This randomized control trial, double-dummy, parallel group treatment arm, a multicentric study which involved administering Remo and Vilda or EMPA and Lina or as a fixed drug combination, and people looked at the efficacy and safety in people who were on metformin and failing to reach targets. The individuals who participated in the study were standard adults between 18 to 65 on metformin 1500 mg or more, HbA1c 18% or 11%, 8 to 11%, sorry, and they were given with Remo, Vilda, or Empalina, and the metformin was continued. So essentially, people got 3 drugs, either it was metformin, Remo, Vilda, or it was metformin, Empalina. The baseline characteristics of these individuals were essentially same in terms of HbA1c, fasting plasma glucose, postprandial glucose, the eGFR, and the body weight. In this study, they included patients whose GFR was more than 60 because both Vilda and Remo have issues of GFR. Now we look at the efficacy. The HbA1c lowering at week 6, week 12, and week 16 was similar with both these agents. So sometimes you find that Remo Vilda is showing numerically different results. Sometimes you find Empalina is showing different results. But one can say that essentially this drug combination was similar to the drug that has already been approved for this use. Same was the case for fasting plasma glucose measurement as also for the postprandial glucose measurement. Weight reduction, as expected, was also seen, and you reached a weight loss of about 1.25 to 1.5 kgs at week 16. And here again, the depth of the bars looks different, but believe me, there was no statistically significant difference between the two. The blood pressure reduction also was seen both in terms of systolic and diastolic. This was also essentially the same. Adverse events, the treatment emergent adverse events were similar. Drug-related adverse events were also similar as also the adverse events of interest. So as for the safety, there was no increased risk of hypoglycemia. There was low risk of genital tract infections versus SGLT inhibitor add-on therapy. And the relative risk for the genital tract infection was less in individuals who received metformin before an SGLT2 combination compared to the SGLT2 inhibitor combination. So the conclusion was that triple drug therapy with metformin, Remo, and Vilda was able to provide glycemic reduction, which was similar to and comparable to the approved triple drug combination metformin, empagliflozin, and linagliptin. The triple drug combination was not observed to have any additional safety concerns, and the extra glycemic benefits in terms of weight, blood pressure reduction were also observed with both these agents. So the benefits that you see are again the same, which we have talked about earlier, that you have got the possibility of combining metformin, SGLT inhibitor, and D4 inhibitors, which work in concert with each other. They do not inherently cause hypoglycemia. SGLT inhibitors offer the possibility of weight reduction and blood pressure. And these agents have the potential for cardiorenal protection. So FDC is conceptualized as a potential solution for looking after the issues of hyperglycemia, because innately the HbA1c lowering will be greater with these 3 drugs. Also, they do not cause hyperglycemia, so you can have what is called a tension-free or a stress-free addressal of the issues without the fear or concern for hypoglycemia. With that, I'll stop sharing the slides and take questions on this combination, because as discussed earlier, we are looking at the possibility of glycemic control without the usual deterrents of hypoglycemia and the number of pills that are to be given these patients. So the compliance will be improved. If the compliance is improved, we feel that there is a potential solution to inertia, to non-adherence, to discontinuing therapies. And if the therapy is offered at a cost which the people can afford, then I think it looks like a good combination for individuals who are not going to get control with monotherapies or even two agents before we consider injectable therapies. And if you can have everything in one pill. The other good thing about this combination is that unlike certain drug combinations wherein you use with certain gliptins, half the dose twice daily, say when the drug can be given single time. Here, you are administering drugs which require for the pharmacological benefits based on pharmacokinetics and dynamics. Vilda has to be given and is being given largely as a twice daily preparation. The remogliflozin also has to be given twice daily combination drug. Metformin also is usually given twice daily. So you are not deviating for the sake of administration of the drug from the usual dosing pattern. And it not only improves the compliance, but also administers drugs in the manner and fashion that they are to be administered for optimal therapeutic benefit. Thank you.
Thank you, sir. So we have a few questions from the audience.
Yes.
If there are any questions, please post it in the chat box. So one of the questions is the usage of this combination in drug-naive patients. Can this be used, on what precautions should be taken in such a scenario?
As I said, triple drug combination is recommended in individuals if you are unable to control with one agent or two agents, and it is even given for people whose HbA1c is more than 9 if they do not have symptoms. One should be reasonably certain and sure that one is not dealing with type 1 diabetes. So you will not have patients who are asymptomatic, but in individuals whose HbA1c is, let us say, more than 8.5, two drugs may not get you to the target. And often at time, triple drug combination is used in these patients. And one of the components usually is sulfonylurea, which is a deterrent for control because you can have hypoglycemia. So people are a little bit turbid about dosage titration. So in these individuals, you can use this, though there will be some hesitation to use this. And if somebody is in doubt, I would suggest that in areas when you want to use a triple drug combination, but you're not sure, you might treat them with insulin, stabilize them, and then think about what drugs can be given. But that is not for this, but even otherwise, that whenever you're unsure, you should always not withhold insulin therapy. Given that SGLT inhibitors can produce euglycemic ketosis, this caution is all the more valid.
Sure. So one more related question: if the patient is already on other triple FDC or on a combination of metformin sulfonylurea, how would you suggest to shift to this combination of metformin SGLT2?
That is an easier question to answer. If the person in question is already on the triple drug combination and is controlled, but experiencing hypoglycemias or GI side effects on account of the components, or sometimes maybe having even weight gain, then you might shift them over to this because you have the possibility then of not having additional weight gain, and of course the hypoglycemia is going to be erased. So I think that is an important issue.
Yes. So one of the other question was, is there any dosage reduction needed with hepatic diseases?
Well, I think as of now, let us restrict its use to people who are not having a renal impairment, GFR below 60. Let us not use it in patients with hepatic dysfunction because vildagliptin is contraindicated in patients with significant hepatic dysfunction. And those people would probably, even otherwise be taking insulin. So I would not recommend that you use this for hepatic dysfunction.
And when would you suggest this tablet to be taken, before or after food?
I think this is another important thing. Some people used to ask that sulfonylurea has to be given before food. Metformin is given after food. The alpha-glucosidase inhibitors are to be given during food. So how do I take this drug which has got all the three components? That's not an issue here. You can take it before or after food because these drugs have got absolutely no problems. And most people take metformin after food, so you might give it immediately after food, morning and night.
So one of the thing, none of these drugs have any CVOT trials. So can we assume class effects while using for at-risk patients?
I think this is a question which merits some more discussion. It is true that the HbA1c lowering, the weight reduction, and the reduction in blood pressure has been demonstrated with remagliflozin vis-a-vis dapagliflozin in the first study that it was finally approved on the basis of. That is true.
Yes.
Also, the same has been shown vis-a-vis empagliflozin in the forever study. However, we do lack CV outcome data, and I think we are quite candid to admit that, and we should. What we don't have, we don't have. So diabetic patients who've got ASCVD or is about 30% of the population, but there are other diabetics who have issues of hypoglycemia, who is worried about weight gain. In those individuals and who are not able to use these molecules because of cost constraints, then there are places for this. And if you're wanting to use the SGLT2 inhibitors which have got proven CV outcome data, then which is also recommended by the ADA guideline, that even in the nephrology segment, CKD or heart failure, they say that use agents which have got a primary cardiac heart failure outcome or a renal failure outcome data. And you can also use agents which have got similar data in a secondary outcome in the cardiovascular outcome trials. So in that particular category with such strong statements for agents which have got primary or secondary endpoint data for renal and heart failure outcomes, I think it will be difficult to push these agents in individuals who got atherosclerotic cardiovascular disease or heart failure or CKD, but there are any number of people other than that in which you can use this.
Sure. As of now, those are the questions. So I'll just wait for 1 or 2 minutes to see if any other questions will be coming. So one of the questions from my side is, what is the issue with compliance since this will be taken twice a day and all the other SGLT2 inhibitors once a day, and also DPP4 inhibitors usually once a day?
No, but I don't think that metformin is often taken once daily, specifically if the dosage is more than 1,000 or 1,500 milligrams. And we are talking about individuals who are not, who are going to require much more than that. So obviously, taking drugs twice daily, if you look at metformin, sulfonylurea, metformin, DPP4 combination, most of those drugs are twice daily. And also, if you look at the SGLT2 inhibitors plus gliptin combinations, only few are available which are once daily. The moment metformin comes into the picture, twice daily regimen is quite possible, and it is there in place already. What you are doing is you're adding a DPP4 and SGLT2 inhibitor to that And I don't see a major challenge in that, because you're going to give just 2 tablets per day with 3 constituents. If you look at the available triple drugs that you have, there also people are going to take it twice daily. And sometimes if you are using alpha glucosidase inhibitor, you are not giving the alpha glucosidase inhibitor with the lunch. That means you are going to give another tablet anyway to give optimal alpha glucosidase inhibition. So I think compared to that, it is similar, but it is able to deliver all the components in one go without problems, and while retaining the optimal pharmacodynamic data. And it will ensure that people take vildagliptin and remogliflozin twice daily, as is the case if one has to choose them for their maximum efficacy.
So there's one more question where you said that theoretically it's possible for the genital tract infections, it's reduced when given with metformin or other DPP4 inhibitors. Clinically, in your experience, is it seen similarly?
I think the numbers that we have with this and the experience that we have with this is too limited to for us to comment that we found lesser incidence. But this has been reported in the literature that the genital mycosis was definitely lower with this in these individuals compared to when they were used, say, with glimepiride. So people said that if you get good control, you will get lesser genital mycosis. But they found that when SGLT2 inhibitors are given with sulfonylureas, the reduction in mycosis was not so much. So it is not a glucose dependent or a glycemia mediated kind of impact. It is more to do with the DP4 inhibition of the candida rather than the glycemic control.
Sure. Sorry, that's it, sir. No other questions coming from the audience. So I'd like to thank you for taking out your time on Sunday, and it's always a pleasure to hear from you about this. And also to the audience, thank you. Thanks a lot for attending this symposium on remogliflozin, metformin, and vildagliptin. And if there are no other questions, then Anuragji, you can end it.
Thank you, Dr. Sharad. I would like to thank all the delegates for joining on Sunday evening, and a special thanks to Dr. Vipin Sethi for such a nice presentation. Thank you, sir. Thank you so much for your valuable time and discussion on the remogliflozin, metformin, and vildagliptin combination. So on this onset, I would like to thank all the doctors, and I would like to say good night to all the doctors.
Thank you. Thank you very much.
Thank you so much, all the doctors.
Thank you
so much, Dr. Vipin.
Thank you. Take care.
Good night.
Bye. Bye.
Bye.
Good night.
Good night.
To introduce for the first time in India a combination of SGLT2 inhibitor, DPP4 inhibitor and metformin, Glenmark Zoltan Care Team launching a match winner combination with 3 match winners in one pill: remogliflozin, metformin and vildagliptin. Remosin MV. 3 match winners, 1 pill.